So coming next, let's welcome our next speaker. That is Professor Yin Minyi from Shanghai Nice Peace Sports Hospital. Today he's going to share with us the Chinese practice over SFA port. Please. Thank you. Distinguished crack worker, distinguished expert from China and the rest of the world. Please allow me to first share my slides. And just now, Professor Nail has already shared with us how should we treat the patient, and especially with complex FP. And I know that you have a very good experience in this regard. So what I'm going to share with you is not like a Chinese practice. It is more like my personal practice based upon the existing evidence. And what would be the tools we're going to choose in treating the complex FP disease patient? Well, first of all, talking about a complex PF, I think all of us have a common aspect. If it is a long lesion, and even normally being completely blocked, the proximal end of the lesion often involves the superficial femoral bifurcation, and the distal end often involves the papillary artery. It is not easy for us to get the cross. And generally speaking, if we use as endovascular treatment, the potency in the mid and long term is also not going to be that ideal. So you can see that those are the traditional bone and the stenting study. And we can see that generally speaking, the lesion length, as we have a longer lesion, no matter which method you choose, the potency rate would be compromised a lot. Maybe I think a bone would be having the least efficacy stents, works better, but still the potency is not going to be very good for the complex FP patient. The longer you place the stenting, the more disease is going to happen in the longer run. Besides the hyperthermia and also deformation of the stent, if the stent is being occluded, it is very hard for us to do the crossover. You can actually use laser, but even you use laser and still the crossover is not easy to be done. So that is the reason the very general balloon dilation along with the stenting placement probably going to be the therapy choice 5 to 6 years ago, but now we don't take too much of those treatments because we believe it's going to hurt the patient and bring some secondary complications. So let's talk about for the complex FP patient, is there any other good choice for us? What would be the advantage of different options? The first one would become the drug-coated balloon or the stent. You can say, for example, like Liban, it actually have the membrane and the fumes. It will not easy to be tilled, and it can actually help to further reduce the possible complications in the previous trials, especially if we use Liban in treating the long lesion patient. Generally speaking, the patient does show good treatment outcome, especially the clinical trial in Japan. You find out the average lesion is actually close to taste D. But generally speaking, its 2-year potency still be very ideal, almost can reach around 80%.
So we can see 20 centimeter lesion compared with BMS, stent-graft has better patency. So from this result, we can see that the Vibon results are very good. But if we look closer, we may find that actually for such good results, there are some preconditions in this study. First of all, the anchoring zone should be very healthy. There shouldn't be any plaques, and also we all the lesions and the vessels were using IVUS for measurement, and also it's overspecified to 20%, and also there's a pre-dilation, post-dilation, and also 6 to 12 months dual antiplatelet treatment. And after all of those strategies, the mid to long-term patency is good. So there's this individualized treatment. Another one is the DCB. In China, now we have more options with regard to DCB. We understand the mechanism and also the pros and cons. As for the reported results of DCB, very good. We have the China results and the Europe results and the US results. You can see over 20 centimeter long lesion. You can see primary patency according to the published results. Primary patency over 80% or even between 80 to 90%. We know that the FDA, we have Medtronic DCB used for lung lesion in 2018 is approved for the application in lung lesions. You can see the lesion length is close to 30 centimeters and the 1 year patency rate is close to 90%. That's really amazing and surprising. Very good results. But if we take a closer look, we can see that although the lesion is 25 and 30, the primary patency is maintained at 80%. So seemingly compared with the graph, it has even better results. However, for DCB to play its role, there's a very good vessel preparation, and for the dissection A and B, the DCB can exert its role of maintaining the patency in lung lesions. However, most of the occlusion type is not A and B type. The mild dissection mostly is C and D type lung dissection. So DCB for the treatment of lung lesion, the effect is achieved with certain preconditions. The vessel preparation should be very good for the lung occlusive lesion. And actually, from access, it may define the final results. So just now, the professor introduced how we enter into the true lumen and the crossing and do the crossing. Actually, after the dilation, how to ensure the better results. And we know that we have a high pressure balloon, cutting balloon, and also the positive wave balloon. However, we don't talk about it now. We just emphasize the vessel preparation is very important in order to ensure very good DCB results. Next one, debulking. We also have laser, we have Hawk, we also have Rotarex, and that's for the plague removal. And so far, we don't have orbital atherectomy. And all of those debulking devices can remove the plague and also reduce dissection. And also after debulking, we use DCB. It helps with the drug absorption. Theoretically, it's very good. And from Medtronic's study, we can see after debulking, the immediate lumen gain very good compared with the balloon. It has better immediate lumen gain. However, in study and also in practice, we found that after using debulking, if we compare it with POBA, actually the mid to long-term results not so good, and also the intima hyperplasia rate is higher. You can see in clinical observation, it's the same results. Debulking, we cannot say that we only debulk the hyperplasia and or atherosclerotic lesion, and we cannot ensure whether or not it will affect the other layers of the vessel. We know that in America there's some new device, but it's not introduced to China. So we need to use it in combination with DCB in order to avoid or reduce the intima hyperplasia. And for debulking, sometimes for the mild calcified plaque, we also do debulking. Actually, from the study results, for the mild calcification, actually debulking plus DCB compared with DCB alone, actually no difference. For the moderate to severe calcified lesion, debulking can play a better role. And how can we use it better? Actually, for debulking device, it has a very complicated mechanism. After the debulking, the residual stenosis should be less than 30%. If we don't do very good evaluation, the residual stenosis more than 30%, actually the final results may be poor and there may be restenosis. And so for debulking device, how can we have very good results for moderate and severe calcified lesions? We can use debulking, and also residual stenosis should be less than 30%. Personally, I think I will use it with a combination of DCB in order to reduce the intimal hyperplasia. So for DES, in China, very early, we have Silver PTS, originally owned by Cook, and also now we have Illuvia by Boston Scientific, and we have some paper publications, but not so much, and we mostly use the two products in China. 5-year results, you can see this is a real-world study, over 1,000 cases. It's a study conducted in Japan, and the complicated lesions are dominant because previously in the clinical study, it's mostly simple lesions, but in Japan study, you can see it's task C, and the average lesion length 15, and the CTO 7%, and one outflow, about only one outflow, close to 40% for lung lesion, for severely calcified lesion, occlusive lesion, especially in combination with diabetes. After using the DES, there may be better clinical benefits. And if reversely, when we need to use such a stent, especially for the complicated lesions, if we use DES compared with the BMS, the results will be better. In summary, for the FEMPOP complicated lesions, previously, we only do balloon dilation, and after that, we deploy a stent. Actually, the results may be poor. The mid to long-term patency not so good, and the new device, DCB and debulking device, they all have their benefits. However, they have different conditions. For DCB, vessel preparation is the key. When we do the vessel preparation, there shouldn't be the severe dissection and recoil, and in such a case, DCB can have very good results and maintain patency. And for the graft, actually the anchoring area should be healthy, and the diameter selection override 5 to 20%, and also the post-intervention medical treatment very critical. And as for debulking, very good device. Most of the debulking devices are now included in the reimbursement, and different debulking device has a learning curve, and we need to use it well. And also the residual stenosis should be less than 30%. We should use it in combination with the DCB to reduce intima hyperplasia. After using all of those strategies, if we need to use stent, then DES is recommended for those with diabetes and kidney function issues. DES proved to be better in clinical results. So we have different and complicated diseases. However, we have multiple devices and options, and we should choose a appropriate strategy, appropriate device in order to exert the role of the device and also maintain mid to long-term patency. So that's all from me. Thank you very much. Thank you very much, Professor Min Yi. Thank you for your sharing on the FEMPOP lesion treatment. And also, Professor Min Yi talked about the international studies and the results. So, Professor Walker, any comments from you on Professor Min Yi's presentation? So, any comments from Professor Walker?
Yes, excellent presentation. And you addressed the challenges that we face with this. Obviously, the covered stents that you showed, ideally, we don't want to use those in small arteries as you presented. The vessel must be at least 5. And if we use these, we must screen the patient because end restenosis can occur. It's less now that we're learning not to oversize the ends, and the device has been scalloped at the end, but it still does occur. And if we don't document it, because these patients may not have symptoms, and if we do not treat it, often it presents as reocclusion. But I agree with what you've said. We're entering a new world and a new era of endovascular care. And later, perhaps we'll ask Dr. Finn just to comment on some of his thoughts with this recently published study, because I think there are many pitfalls in the best CLI study. But we certainly have many more lectures tonight. Let's go through some more of these, and then we'll speak all together. But excellent presentation. I enjoyed it.